So Paul said he wanted something provocative. So this is something I gave to the UK Intensive Care Society, and basically it generated lots of good discussion, and it was hopefully quite a fun talk. But you'll see from the title where I'm going. Okay, so this is a discussion I had with a patient's daughter. Your father has a chest infection. The daughter said, "Thank God, I was so worried. The doctor I spoke to in the emergency department told me he had sepsis, so I thought he was going to die." So it's got, unfortunately, certainly in the UK, you can tell me about Canada, but I think it's probably much the same, this very, very negative connotation. And unfortunately, I think we're living in the world of planet hype. And what obviously the media do, I'll come to the media in a minute, but also I think the medical community are at fault too, is we highlight a problem, we have to blow it up, we have to keep blowing it up, sensationalize it, weaponize it, and create Project Fear. So in the UK, we have a body called the UK Sepsis Trust, which is essentially largely a one-man band. It's actually run by an intensivist who works in the Midlands in the UK. And he's very good at marketing, give him his due. And you'll see here we have gory headlines like, "Every year in the UK there are 150,000 cases of sepsis, resulting in a staggering 44,000 deaths, more than bowel, breast and prostate cancer combined." Scary. And sepsis kills 44,000 people every year in the UK. Every 3.5 seconds, someone dies from sepsis. So this is me doing my ward round, and as you see, the bodies are piling up. Oh, 3.5 seconds, 1, 2, 3.5. Oh, look, there's another one. So, you know, this sort of headline banner to the lay public, I think, is intended to scare. A few years ago, it was 37,000. And more recently, it was inflated to 52,000. So you have to keep blowing up the numbers, because that obviously keeps people's attention, the newspaper's attention. And as you can see, you have to personalize it. 52,000 mean nothing, but you have to try and identify someone. In this case, Liz Frew thought she had a tummy bug. 3 days later, she was close to death. And the message was that acting quickly can save 14,000 lives. So large numbers of these patients, a quarter, a third, can be saved by acting quickly. And the newspapers love it. Unfortunately, we're blessed. I don't think perhaps blessed is the right descriptor, with various newspapers who revel in gory bad news stories. So clearly, depending on where you live in the UK, deaths are much more common from the silent killer. And again, they pick on, you know, the cases that go wrong. Bungling doctors misdiagnosed his blood poisoning, thinking it was flu. The rash was a virus, you know, patients blame doctors. All-out war on sepsis. Blueprint to end the sepsis scandal. This was a fairly infamous case where actually there was lots of institutional errors. The poor doctor got blamed, and then she was absolved, and there was probably some racial aspects to it, which I won't go into now, but you can see the gory headline: "Sepsis death doc can work again." And if you type in, you know, sepsis and deaths, you get lots of photogenic young people predominantly being portrayed as the victims of bungling doctors, bungling nurses, bungling hospitals. As you see, predominantly young, fit and healthy looking people. This was an interesting paper that came from a group in Glasgow. They looked at what newspapers were reporting, and they looked at the broadsheets, the more upmarket, the middle market and the tabloid papers. And you can see the number of stories of sepsis outnumbered 2 to 1 the number of stories about antimicrobial resistance. But if you look at the proportions, you know, the majority was one particular newspaper, the Daily Mail, which has a direct link with the UK Sepsis Trust. The lady who does their PR stuff used to be a journalist for the Daily Mail. And if you look at the ratio of sepsis to AMR stories, they're approximately 1 to 1 in the broadsheets, between 2 to 1 and 5 to 1 in the middle market papers, and there's a large preponderance of sepsis stories, averaging about 14 to 1 in the down market papers. And if you look at these sepsis 415 stories, the vast majority were on human healthcare systematic factors causing the problem or individuals, and they identified the healthcare professionals screwing up according to their stories. And the lawyers love it too, so they jump onto the bandwagon, and obviously they're in it for a reason, and it's not just to help the poor bereaved families who are suffering so much. There's a vested interest for them to win cases. And I love this oxymoronic name for a solicitor, Truth Legal. Problems occur when doctors, nurses, other healthcare workers fail to spot the signs that someone may be suffering from sepsis. Many of the symptoms could also be indicative of other much less serious ailments, absolutely. And the rise in the number of cases brings with it an increased prospect of more cases that are missed or misdiagnosed. At Truth Legal, we have nothing but sympathy for the hardworking, overworked health professionals. That's very nice of them. However, they continue. Sepsis brings life-threatening, life-changing injuries. These consequences can still result from properly diagnosed and treated sepsis. However, they're most likely to occur when healthcare professionals provide substandard medical care by not thoroughly following guidelines, resulting in a breach of duty. You may be entitled to claim compensation. So very sympathetic for the overworked healthcare professionals, but we can screw them for all they're worth. And again, you've got lots of these sorts of stories. And unfortunately, you know, the BBC and others also revel in these sorts of stories. You know, this lady, no hospital bed, she was forced to wait in an ambulance. She died after she was refused antibiotics. And again, interestingly, the partner was represented at the inquest by a clinical negligence solicitor. And so interestingly, how did all the media know about it and turn up? And you can see the press release was put out by the head of media relations for this clinical negligence law company. Unfortunately, our politicians get in on the act too. So we have a wonderful, in inverted commas, Secretary of State for Health, the healthcare minister, Matt Hancock, and he tweeted this: sepsis kills over 52,000 people every year. Each death a preventable tragedy. So don't worry, we'll look after you. We'll save you from these nasty, useless doctors and nurses. And there was a threat of fines if they broached new rules. And I ran a trainee course, and again, the junior doctors who come on this medical emergency course were, complained about being reported, day text, for not giving some antibiotics to someone they didn't think was infected because they ticked boxes. Oh, they had a bit of a tachycardia and a bit of a temperature, and they were reported for not giving antibiotics. Other doctors chimed up too. So let's go back a step and let's look at data, because I believe good data are the answer to most things. Sepsis is the tip of the infection iceberg. And we wrote this intentionally provocative article in The Lancet a couple of years ago now. And we basically pulled data. So the second author, Matt Inardakim, is the clinical advisor on sepsis for the National Health Service. He's an acute medical physician working in the south of England. And basically, we pulled bits of data together. In England, there are 55 million people. GPs write a total of 33 million antibiotic prescriptions a year in England. Patients admitted to hospital as an emergency with a discharge code of bacterial infection or sepsis counts up to 1.7 million cases in a year. However, only 44,000 of these cases come to intensive care units. And of those who die in hospital having been through intensive care, so either die in intensive care, discharged to the ward, but don't leave hospital, it's about 13,500. So you can see there's quite a big step down between those admitted with a coding of infection or sepsis and those actually dying having gone through an intensive care unit. So why do so few go to ICU? Again, this is National Health Service data. This is over 6 years. And across the x-axis, it's age. And not surprisingly, small children, 0 to 4 years of age, and older people are the predominant age groups for admission. So older children, young middle-aged adults, you know, there's obviously numbers, but the vast majority are at each extreme of life. However, the mortality figures are very different. The vast majority, more than 3/4 of the deaths, occur in the patient population 75 years and above. And the COVID data, certainly in the UK, virtually mirrors this absolutely. So the vast majority of deaths, which has got a label of sepsis, is in an elderly age group. Nothing new here. William Osler, a good Canadian who did missionary work at Oxford. Obviously, he was probably the most famous clinician of his time. And this is from his book, The Principles and Practice of Medicine, 4th edition, 1901. Pneumonia may well be called the friend of the aged, taken off by it, dying. In an acute, short, not often painful illness, the old man escapes those cold gradations of decay, so distressing to himself and to his friends. So Osler recognized that perhaps sepsis, pneumonia, call it what you wish, may in many situations actually be the last point of call in somebody's life. And often if they're suffering, they've got lots of comorbidities, quality of life is poor. Hopefully it can take them off reasonably quickly and painlessly. And I think we all recognize that patients may be allowed to die, whether it's from or with sepsis, but because they have severe underlying comorbidity, be it terminal cancer, end-stage organ failure, severe stroke, severe dementia, perhaps catching a severe infection afterwards may be a welcome relief for that patient. But there's this important question: do people die of or with sepsis? So again, shock horror story, septic shock, the end game medical condition that claimed Muhammad Ali. But this guy was literally bedbound at the end of his life from Parkinson's disease. He was essentially immobile. So was it the septic shock that killed him, or the fact that his life was an absolute misery and, you know, he could hardly move? So what's the attributable death? This nice paper actually came out a few years ago looking at point prevalence studies in all of the acute hospitals in Wales. And they screened nearly 12,500 patients over 2 24-hour periods and found 839 who they thought were septic, of whom 521 fulfilled the sepsis 3 criteria. They had a SOFA score of 2 or more. And of these patients, 136 eventually died in hospital, but 96 of them were not related to sepsis. Their underlying disease did for them. And of the 40 sepsis attributable deaths, They felt 12 were definite, 28 were possible, and the vast majority of them had a high frailty score. They had a DNA CPR order in place, and nearly half had a limitation of care order, not for ventilation, etc., etc. Similar data comes from the United States. This is a retrospective study done by Chanu Ri and colleagues, and they looked at records of 568 patients who died in 6 hospitals or went to a hospice for end-of-life care. And in more than half these cases, 300 hospitalizations, sepsis was present, and they considered that it was a direct cause of death in 198 cases, so a third of the total. However, most of these cases were due to severe underlying chronic comorbidities. They felt only 3.7% were judged definitely or moderately preventable, and a further 8.3% possibly preventable. And when they looked at the patients, a large number had cancer, chronic heart disease, dementia, and so forth. So there are the numbers. And they concluded sepsis is a leading cause of death in US hospitals, but most are not likely to be prevented through better hospital care. And again, this is non-sepsis data. This is a general study looking at a post hoc review of deaths in 34 English hospitals. They looked at avoidable deaths. The investigators, the researchers, defined as those with at least a 50% probability of avoidability. They looked at 100 hospital deaths from each trust, so 3,400, and they felt the proportion of avoidable deaths was remarkably similar to that American data I've just shown you, 3.6%. And even those with, possibly avoidable, etc., it added a bit more on slight evidence of avoidability between them, added another 6%. So again, most of the people who die, they felt were not avoidable. Similarly, this was done in Norway, retrospective chart review, 1,000 deaths in a Norwegian hospital, and they felt 4.2% were probably avoidable. Okay, what about children? So let's move on to children. And again, heartrending stories of how poor little children's sepsis are missed and they end up dying. And we've got here figures, 1,500 children have died from sepsis in the last 14 months. 1,500, wow, that's a lot. That was in 2016. This is in 2019. This is a more respectable paper. This poor child died, I think he had meningitis, if I remember rightly, and his mother led a very vociferous public campaign, basically berating hospitals and wanting better measures and better care for children with sepsis. But here they claimed, this health editor, up to 27,000 children aged 5 or under are diagnosed with sepsis, and up to 4,000 every year die from the condition. 4,000 every year. That's a hell of a lot. But interestingly, if you go back to the data, these are actual NHS England data over a 6-year period. So the number is far less. So if you average out all of the children between 0 and 19, it comes to about 100, 150 a year. So it's far less than 4,000. Coding has a lot to answer for. They changed the coding guidance, and all of a sudden there was a big jump in cases of sepsis. And unfortunately, that was driven by money, because if you call the patient pneumonia, you got about 30% or to anything up to 70% less income than if you called the same patient sepsis. So just to give you 2 examples, if you call the patient having lobar atypical or a viral pneumonia with multiple interventions, you'd get somewhere about £7,000 reimbursed to the hospital, and it was a lot higher if the same severity of patient was coded as having sepsis. And if you look at patient with infection and sepsis discharge codes, year on year on year on year, there's been this increase. So it's gone up from 1.3 million to 1.9 million, 45% increase over a 6-year period. Whereas those dying in hospital, allegedly with sepsis as the cause, 27%, and the percentage mortality has gone down by about 13%. However, the data's conflated, so the newspapers and the BBC all love it because they picked up this jump in cases. Shock, horror, sepsis deaths jump by a third. No, they haven't. They're just being reported in a different way. And when we looked at all-cause mortality, we looked at a variety of different hospitals. The whole number of patients dying across these different hospitals has been pretty flat over a 5-year period. So things haven't really changed that much, despite, so number of people dying are the same, but more are labeled as having sepsis. And the other problem is also that it's generating changing practices. So the government, because they wanted to cure sepsis, they basically pushed trusts to give antibiotics within an hour of arriving in a hospital emergency department. And as you can see, what that did was steeply increase the amount of antibiotic used, and there hasn't been, as I showed you earlier, any significant drop in mortality rates. And unfortunately, we used to have good resistance patterns to antibiotics. It's now sadly on the increase in the UK, and we're catching up. We're still behind, but we're catching up mainland Europe. The good news is that people don't necessarily agree, and the little people, us, are fighting back. So when Hancock came out with his tweet, lots of people answered. I don't tweet, thankfully, but lots of people answered, replying what they thought of him. You have lied. They're not all preventable. Stop spreading disinformation. Faster is not always better. We need to protect antibiotics from unnecessary use. Sue Crossland is the current president of the Society of Acute Medicine in the UK. Lots of comments being written in, And again, when we wrote our article, again, lots and lots and lots of people were writing in, basically agreeing with us. So literally about 1%. There were a few thousand tweets and Facebook things, etc., but about 1 or 2% didn't like the message, but the vast majority were relating to what we wrote because they basically were in agreement. Sorry, these are just some of them, but okay, nearly finished. Sorry, I've just put a few there, but you'll see the strength of view being held by lots of my colleagues. And actually, it wasn't just in the UK. I think there is good news. So don't get me wrong. I think educating the public is good. I think it's good that people are aware of being ill and presenting to medical attention. But I think there's this fine balance between education and scare tactics, and not to the point of inducing unnecessary fear and putting unnecessary pressure on the healthcare profession. We all get it wrong, me included. Wouldn't it be nice with the eye of retrospect to make sure everything we did at the time was the right thing? And often the patient's symptoms, signs, features evolve, and so they may not present as having sepsis, but that might occur over time. So especially for general practitioners, emergency departments, I think it's a lot harder for them because they've got to make the call. Do we send the patient into hospital, or are they okay to be sent home? So I think, yes, we don't want poor practice, but we don't want to drive bad practice either. And I don't think it should be used to weaponize against doctors, nurses, hospitals. We do need to take sepsis seriously. I've spent many, many years doing research on it, etc. But again, it has to be proportionate. As I mentioned, we shouldn't condone bad practice, but it is a difficult diagnosis to make at the onset, and it's even harder, especially in elderly people with multiple comorbidities. There are nice studies on that showing that the delay is significant in these patients because it's often hard to make that diagnosis. And I think certainly in the UK, the powers that be in the NHS Department of Health have recognised that the hype has gone too far, and now there are moves. It was a bit delayed with COVID, as is probably every other thing that's happened in the world in the last year and a bit, but there are moves now to have a much more balanced messaging and to put the emphasis on good clinical management, and also to try and improve on the quality of coding. And I think, again, something we can touch on in discussion, but I think early diagnostics, they're coming, more and more are coming. And I think in the next 10 years, there'll be leap years ahead of where we currently are in being able to discriminate patients with infection or patients who are infected who will go on to develop organ dysfunction. I think those tests are coming through, and it'll be, I think, a huge boon to us as clinicians. I'll finish there. Lots of hysteria. These were for the Beatles. Probably none of you are old enough to remember. I am just. But thank you very much for listening. I'll hand you back to Paul.
Thank you very much, Dr. Singer. That was an exciting presentation and a nice take through your own personal tweet responses. For somebody who knows so much about Twitter, I would have thought you'd be on there all the time.
God forbid.
I will hand off the reins to Dr. Arnfield to maybe administer some of the discussion.
Thank you so much, Dr. Singer. I'm the Canadian who was harassing you on your mobile phone only moments ago. And I think aside from the provocative talk, you also, to be able to pivot in whatever you were doing when I called, to be able to then administer an international lecture on a hairpin turn also needs to somehow be incorporated into our consideration of your contribution today. So thank you for that.
Very sweet. Thank you.
I will open it up to the constituents here to ask any questions. Just you can either unmute yourself, and I think Claudio is doing so with the Guinness in hand. And then if anyone wants to type any messages into the chat, or otherwise just raise your hand using the virtual Zoom feature, and we'll try and find you.
I should say, can I, just as a quick thing before questions come in, I had the pleasure of visiting London, Ontario a number of years ago, and I'd see obviously lovely faces like Claudio and so forth. So it was just, I had a great time, and just to acknowledge that it was great fun visiting.
Claudio can expand on that. I think he was mentioning that before you joined. Yeah.
Mervyn, while we were waiting for the time zones to catch up, I was asking the group here if they knew any little known facts about our expected speaker, and one of them that they didn't realize was that this isn't the first time that you're visiting London, and the previous time was for real, and we would so much look forward to having done this in real again, if not virtually. The other little known fact that I brought up to them was that our current hospital ethicist spent a few months in your laboratory, and that you're best friends with the founder of our critical care program here, Bill Sybill, who unfortunately is not with us anymore. So I pulled out a Guinness. It's the closest thing I could. I saved one in my fridge for today. It's afternoon. It's in the evening there, and it's afternoon here. So I thought it was all right.
I look forward to sharing it with you.
But really enjoyed your presentation. I think. I wonder, do you think some of this is unintended consequences where, we all have to write grants, and in our grants we have to, make a good point about the impact. And as you pointed out, it does cause more deaths than prostate cancer, but yet we have, huge fundraising activities here for research into prostate cancer. So how much of this do you think is just unintended consequences from some good intentions gone awry?
Yeah, I think so. I think, yes, I do research. We all fight for research funds, and you have to create noise to get funding bodies interested, let alone philanthropic donations. And again, for those of you old enough to remember, you know, HIV when it came along generated huge amounts of research funds. We had in the UK, there was a big thing about mad cow disease, and lots of poor cows got slaughtered. Again, huge amounts of research money got funded or funneled into mad cow disease. But again, thankfully, we haven't seen that become a problem. So again, you know, it's a natural thing that researchers want to talk it up, to draw attention to the problem, to then generate funding. And likewise, newspapers, you know, as I sadly indicated, the media don't like good news stories by and large. You might get one little snippet at the end of the news, but by and large, they revel in you know, especially the individual case where some shock horror catastrophe occurred. And I think, you know, hopefully you'll all agree there are a minority of cases, and yes, it's a tragedy if something does go wrong that could be avoided, but I would like to think that, you know, millions of people do go through healthcare every year and get good treatment.
We'll turn it over to, is it John Landau or John Basmaji next? I'm not sure which John it is.
Landau.
Okay.
Thanks very much, Professor Singer, for a very engaging talk. One thing that I was curious about in sort of the middle of the discussion, where you talked about sort of a lot of that sepsis death hysteria being around things that are essentially futile care admissions for people that are sort of passing of natural causes. And I was curious, sort of culturally in the NHS and your experience clinically, what the public's acceptance is of that type of futility in the context of this sort of media propagated hysteria of these unavoidable sepsis deaths. Because I think locally, certainly, like, our culture is to try to make sure that we communicate this with families to the best of our ability with varying levels of success. And I think we're spared of a little bit of that media hype around the monster of sepsis that can sometimes be the sort of admitting diagnosis that brings someone to the end of their life into intensive care. So I'm curious how that is managed culturally in your environment.
Yeah, it's a really good question. I think culturally, and historically are the two issues. London's very multicultural, and again, depending on the culture stroke ethnicity, you can get, for example, I'm non-religious Jewish, but the Orthodox Jewish fraternity believe, you know, death is, you know, it's, you know, basically until there's not a breath left in the body, you should do absolutely everything. And we see that with the religious Muslims as well. And that's their, you know, strongly held belief. You know, that's the interpretation from the Bible, the Quran, etc. So again, you have some cultural mixes or influences. Certainly now, again, you know, whether it's the sort of whole slew of television programs where they show people having cardiac arrest and getting successfully resuscitated, I think it's a disproportionate number compared to real life. And yet the perception is, oh, people survive. And so therefore, why doesn't my loved one get everything? You know, we had a big problem with COVID in the UK. As I mentioned, the vast majority of people who died were over 75, yet the average age of patients admitted into critical care in the UK was 60. Right, interesting. And yet you know, and there was, I'm not saying it was rationing, but there was probably more stringent use of healthcare resource than we would otherwise do, because you've got the capacity to take people into intensive care who, you know, deep down are very, very likely to die, or even if they survive, their quality of life will be fairly horrible. So what we try to do, and certainly in our hospital, I think increasingly we try and engage the teams and therefore the families and the patients before they get to intensive care. Is this what you really want? You know, these are the options. We'll put you through a load of misery, because being an intensive care patient, I don't need to tell you guys, is fairly miserable, with no guarantee of surviving or quality of life. And we try and give some realistic idea of what the patient will go through. And many do opt to say, no, I don't want any of this, or you agree on a ceiling of care. And I think, thankfully, because in the good old bad old days when I was a junior doctor, we were much more paternalistic. You know, people, you know, families, patients didn't have that discussion. They were just made not for CPR without that. And now, thankfully, you know, we are obligated to actually talk to the patient, and if they're not able to, you know, take part in those discussions with their next of kin. There was I'll tell you a horrible story. Somebody reminded me. It was a hospital in the southwest of England, and their DNAR thing, there was a stuffed bird which they put on the the end of the bed, and that was a signal. This patient's not for CPR. So if you know, so the relatives didn't realise the significance of the stuffed bird. Thankfully, we've progressed beyond that.
Fascinating.
The good old bad old days. That's
Yeah.
sounds a bit appropriate.
I'm good, but I think you know, there's lots of things I sort of shudder at now.
I didn't know if it was a dead parrot.
Actually, it wasn't. It was I can't remember what he told me, but it was. I remember asking him, was it a dead parrot? But yeah, for those obviously Monty Python aficionados. But again, I was talking about Monty Python on a ward round, and everyone looked at me blankly. So I thought, oh gosh, I'm a dinosaur. Not that you are.
Dr. Bosman has contributed in the chat that a slightly more gentle approach that I guess is done. I didn't know this at UH is a butterfly goes on the bed or above the door, which I guess is, I didn't know that was true. Dr. Hedera, our chair, has the following question.
So thank you very much for the, again, very interesting talk. I guess I'm going to ask a question or make a comment slightly similar to Claudio's and the point that you made about philanthropy, you know, grant funding, but I'll take it in a different direction, which is identity. So one can argue that you cannot be a patient, you cannot be a doctor without a patient. Mm-hmm. And cardiologists have patients who have heart attacks. Nephrologists have patients who are on dialysis. Who are we exactly? You know, the post-cardiac surgery patient that comes into ICU to recover is not our patient. The patient with an aneurysm belongs to the quote-unquote belongs to the neurosurgeons. The patient with lupus crisis belongs to the rheumatologist. The DKA goes to the endocrinologist. So if sepsis isn't a problem, a massive problem, then do we really exist?
So we need ownership of a condition.
Well, we need a problem.
Yeah.
It's just like NATO announced that China is a threat.
Yeah.
In order to continue to exist.
To be fair, I'd not thought of it from that angle before, but I'm not disagreeing with you. I like to think we can talk about, you know, and dare I say, you know, it sounds awful, but COVID was extremely good for putting critical care in the public eye. It was sort of, in fact, we were the first ICU, the BBC, but again, there was initially an embargo on news or media crews going to ICUs in the UK because the government didn't want to let the public know what was going on. And then they realized it actually might be useful to actually let people know quite how serious this condition is, both in terms of people dying and in people who suffered really or suffer really badly yet survived. And actually we were the first unit that the BBC actually came into, and it actually had a major effect. And you know, there was virtually every night there was a program with, you know, on a news program featuring intensive care. So I think in terms of raising our profile, you know, sadly, COVID was actually very good for us. But, you know, I take your point. I tend to use, obviously I'm into sepsis, but I tend to use the really, really sick patients that others can't look after, you know, so that's my little handle. You know, we're the point of, you know, last sort of last hope, I think. But, you know,
I say to the possible administration, we're the banker of last resort.
Exactly. So when all else fails, we're here. Yeah, indeed.
That's really I often describe that we negotiate with death, and as basically as our vocation in one form or another. Though at one death every 3.5 seconds, that's a lot of negotiation.
Indeed.
Dr. Leeper is next in the queue for questioning.
Yeah, my apologies. Based on my better understanding of time zones, it's lunchtime here, so I had to go get my food from the delivery guy. But I missed. So I kind of left during Landau's question, and I heard Claudia's. It sounds a bit like mine. So my question, Dr. Singer, is what got the media, in particular the print media in England, so interested in sepsis? Like, I gather the English read papers more than the Canadians do, but boy, I don't feel like Canada is remotely as interested in sepsis as it seems to be in England. Do you have a sense for, is it the unintended consequence that Claudio said from publishing it, or what do you think the issue is?
I think I alluded in my talk, you know, this guy who runs the UK Sepsis Trust in cahoots with Next Journalist, and he used to, the medic used to run a company, so he was into marketing. So therefore he knew, you know, what buttons to press, and it's very much, and you'll find probably the same in Canada, but like, you know, 500 people die in a train crash in Mongolia, that gets no news. But if there's one British person in that 500, then it's a story. And then the journalist can go and interview, you know, the grieving sister of the one victim, and yet otherwise we don't get to hear about it, or the flood that kills 20,000 people or whatever. And so you have to sensationalize, and unfortunately, I think we probably got more down market tabloid papers than Canada, from my experience, but you can please do correct me. But, you know, they love these horror stories, you know, and we also love building up people and then knocking them down again, whether you're, you know, Meghan Markle or David Beckham or whatever. So unfortunately, it's a national pastime. Yeah,
I wonder if that's true, because I do think, you know, anecdotally, when we all visit England, there are a lot more of those big papers being read on the tube and stuff, the Mirrors and Mails and so forth. And I think maybe it isn't just sepsis, because, you know, like Elaine Bromley and airway death was made a really big deal of in the UK, whereas we've had, I'm sure, many such similar cases in Canada, and they never ever make the press. They never get to be a big deal. So there's something about the culture of the UK that capitalizes on these tragic stories.
I think it's also the other way around. Somebody told me, again, you guys can correct me if I'm wrong, but the public still hold Canadian doctors in much higher regard. Oh, you're agreeing? Yeah,
well, you know, Dr. Singer, I think when you asked Canadians a couple of years ago who to name as the best Canadian of all time, they turned down Wayne Gretzky, they turned down famous hockey players and politicians, and they chose Tommy Douglas, who was the guy that invented universal health care. It is this moral superiority we hold over our southern neighbors and shake out as this pride point. And so we are desperately afraid to say anything bad about our health care. It's like, it's the only thing we have going for us. So we're like, well, like the Leafs suck, but our healthcare, it's great. It's the one thing we hold. So you're right. We're afraid to go after our NHS. I think we're probably checking to say it. Maybe we shouldn't be.
So it's probably you're atypical and we're fairly typical of other countries. Yeah, long may it last for Canada.
Yeah. Well, yeah, that's a debate for another time, probably. You know, the flag waving about Tommy Douglas. Dr. Cameron, do you have a question?
Yeah, I just had a question that I wanted to draw back to a paper you wrote a few years ago. And the statement was that with respect to vasopressors or catecholamines in sepsis, it was that we are therefore still between the scilla of compromised tissue perfusion and septic shock and the Charybdis, I don't know if I'm pronouncing that correctly, of the complications of currently recommended first-line treatment. So I guess I'm curious how you might update that in 2021, but also sort of more broadly, you're talking about the lack of attributable or potentially intervenable or reversible deaths in septic shock. It's a fairly small preponderance of numbers. So without a tremendous amount of evidence-based therapies, and you're discussing catecholamines as one, what is the significance of defining and diagnosing sepsis?
Right, that's a very nice question. I'll preface it by actually referring back to Bill Sybill, who hopefully some of you, obviously Claudia remembers him and some of you will remember him, but one of his great skills was physiology. He loved physiology. And I again, don't know in Canada, but certainly in the UK, it's a disappearing art. And so there's now a sort of brainstem approach to, you know, let's just follow the guideline, and it says get the blood pressure to 65, you know, but and again, not well, I will be rude, not being rude, but I will be rude. But you've then got these binary trials. Let's keep the blood pressure randomized, half to have a mean of 65 and half to have a mean of 80. You know, again, that's nonsense. You know, we need to personalize our care from a physiological point of view and see what suits the patient in terms of, you know, acidosis, urine output, etc. And so to my mind, you know, there shouldn't be these rigid rules. There should be, yes, guidelines so you can think about it, but you're allowed with your clinical acumen to actively sort of go in a different direction or veer away if you can justify why you're doing so. And I think this personalized medicine approach, you know, I think is really badly needed. Unfortunately, sort of drugs and support devices preceded diagnostics. And so, you know, we're now looking for this sort of companion diagnostics, theranostics, etc. And if you look, again, I'll mention COVID, it's fresh in our mind, but I don't know how many of you have looked at all like this in detail at the papers. Usually things are buried away in the supplement that are really interesting. But for example, you know, we're all encouraged to give steroids, and we're all encouraged to give tocilizumab. But if you look at the data, women don't benefit at all. The only ones that do are men. And again, there's ethnicity differences, and there's time of symptom onset differences. You know, so again, what does it all mean? So it means some people are benefiting from this one size fits all approach, but some people are being harmed, or it's not helping them at all. And, you know, if you look, I did a talk a few weeks ago, on COVID, and if you go to clinicaltrials.gov, there are something like, I think it was 2,300 interventional trials are logged on, 2,300, and about 600 are phase 3 studies. And how many of them have actually shown a big difference, or any difference, or even a negative effect? So again, it strikes me that we've just rushed in, applied the same treatment to everyone without thinking, well, logically, tocilizumab will likely work better in people with high interleukin-6 levels. And yet we know from the literature that at least half the patients in intensive care with COVID don't have high interleukin-6 levels. So you're giving a drug aimed to block something where hardly any of it's, you know, the same as you and me at the moment. And yes, we were given interleukin-6 for a reason, so we need some of it. We don't want too much. So that's my argument, that we're being sort of forced by guidelines to dichotomize, do this or do that, when the truth is somewhere in the middle. And yes, we use the things we're used to, so we shouldn't abandon everything we've learned. But again, we need to tweak, titrate to that individual patient in front of us. And if they're going in the right direction, it doesn't necessarily mean they'll survive, but at least if they start passing urine and the acidosis improves, that's generally a good sign. So again, that's what we do in real life. So, you know, that's my big message, you know, the Sybill message, you know, apply physiology to the patient. I think Claudio's nodding. I think he's a disciple too.
Hey, Claudio, you got a follow-up question?
Claudia is now an excellent 5 person.
So yeah, I can come back. I know exactly. Yeah, Bill used to always say the ICU is a big a human physiology laboratory. He didn't care. As fellows, he said, "You think you want to try something? Just go ahead. Just measure the response." So yeah, so that's exactly what he was about. This came up yesterday. We had our McMaster Western Resident Research Day yesterday, and somebody did a systematic review on blood pressure targets. So so we had some good discussion, because that's the exact opposite of what you're describing, which is personalized medicine. So that's what I was going to ask you a follow-up question, because I thought when I saw the title to your talk, I thought somehow that the current sepsis definition was going to come into it, because that to me was a step backwards. One comment I've made is every 10 years we come up with a new definition, but I don't think it's any of those have actually, maybe the first one might have advanced our knowledge or insights, but the subsequent ones I don't think can be, traced to any improvement in outcomes. And if anything, this last one's done more lumping into one diagnosis rather than finessing the diagnosis that he said. So just wondering if you had any editorial comments on the current definition.
I'll fight back against that one. I think when we did Sepsis 3, it was Wild West beforehand. And so if you look at, for example, there was the accompanying paper on looking at septic shock, and everyone came out with their different way of diagnosing septic shock. Some people used lactates of 2, some people used lactates of 4, some people used lactate of 0, but if you were hypotensive, some people used different blood pressure targets, etc. And it was just chaos. And as a result, there was huge variability in coding. So for example, if you look at the, I think the New York paper that came out in the registry data that came out in the New England Journal, it was some phenomenal amount of patients admitted into hospital, this is emergency department, were given vasopressors and therefore called septic shock. And again, is that right? And we looked, and one of the things we did, because I think a big driver of what we were trying to do was move SIRS out of the equation, because I think people therefore thought automatically anyone with a high heart rate and a bit of a temperature and a high Y count, oh, they've got infection. Well, they could be traumatized or post-op, surgery or pancreatitis or whatever. But there was this knee-jerk reaction. They've got a temperature. We need to give them an antibiotic. And so it was also trying to differentiate bog standard uncomplicated infection from people who are sicker. They had organ dysfunction, and then the sicker end of the spectrum, the septic shock, where you need both a high lactate and a low blood pressure despite fluid, then that put these patients into a much higher mortality bracket. And so it was essentially, if you have uncomplicated infection when you come into hospital, your mortality rate's about 3 or 4%. If you come in with either a lactate above 2 or a low blood pressure, or just organ dysfunction and everything else is normal, the mortality rate's around 25 to 30%. And if you had the septic shock, Sepsis 3 criteria, it gave you a mortality of about 40 to 45%. And so you had these nice cutoffs. And they're not meant to say, oh, this patient's now got septic shock, we do anything different. We treat the patient in front of us as we see them. It's not that we take them any more seriously because their lactate is 2.1 rather than 1.9. But it's a way of standardizing definitions, coding, epidemiology, and for trials, so that when we enroll people into trials, we're all talking the same language. And I think the best thing, I think we wrote in the paper, please go out and validate it and see if your prospective studies agree with what we found. And if you look, there's papers that I've got from Brazil, Argentina, Germany, France, US, etc., where those mortality rates I've just mentioned are actually holding up across the world. The only place it doesn't is Turkey. So if you're going to go to Turkey for your holiday, stay safe.
Dr. Cameron, do you have a follow-up question?
I just had a question. I think is a slightly different track that I think relates to our Western experience, because at Western, point-of-care ultrasound is sort of a big part of our training program, and in terms of the elucidation and then guidance of shock management. And I don't know if I'll be shot for proposing it, but I'm curious with your experience with the Pacman trial and with completely gutting the PA catheter based on the sort of data and then the trial that you did, do you have any lessons to learn from that? Because it strikes me as, I guess my question is, do you think if there's a trial like Pacman of POCUS that you would completely wholesale throw out the point of care ultrasound as we did with the PA catheter?
Yeah, great question again. The way I would answer that is, unfortunately, people only read abstracts. And if you actually look in the paper, because when we did Pacman, and so again, for those who aren't familiar, there was at the time, 10, 15 years ago, probably, if not longer, there was a big debate about the PA catheter. Did it make any difference to outcomes? And there were studies in France and the US which just randomized you either got or didn't get a PA catheter. In Britain, we were using a lot more non-invasive, and there was complete sort of equipoise in that half the investigators said it's not a case of PA catheter or nothing. It's, you know, so half said yes, they were happy to randomize on that basis, but the other half said no, it's a case of invasive or non-invasive monitoring of cardiac output. So half believed you did need it. And interestingly, so we designed the trial that both sides would be satisfied. So they were sort of a priori secondary analyses. And interestingly, over the course of the trial, more and more people or units migrated from the don't do anything or don't do any cardiac output hemodynamic monitoring apart from, you know, CVP line or whatever, into the non-invasive cardiac monitoring. And we did a post hoc paper, well, a paper that came out in CryptCare Med, where again, it wasn't powered for a difference, but it did look as if you had the patient managed non-invasive cardiac output monitoring, there was a signal to benefit, whereas the opposite was seen if you did nothing and just relied on clinical gestalt. So, and I think it's the same with POCUS. You know, it's like everything. You will pick up some patients where it will be incredibly useful, but it will be swamped by the 95% or 98% where it won't make a big difference. You know, but it's the same with a lot of what we do. And we're looking at marginal gains a lot of the time, accepting the point I made earlier that a load of people will die anyway, regardless, because of their underlying comorbidity. So I think in terms of the best care we can give to an individual, yeah, if you use POCUS well, because unfortunately there's sort of sometimes rubbish in, rubbish out, and we've all experienced that, but provided it's done properly and well, it can be incredibly useful to that individual patient sat in front of you. But put it into a big trial, it's a bit like pulse oximetry. You know, there's never been a study showing pulse oximetry works, but would we want to relinquish it? So,
well, Paul, it sounds like rubbish in, rubbish out. Somehow Dr. Singer has seen your POCUS work, but on a similar note, though, Dr. Basmaji in our group, John, if I could tap you to comment on, like, exactly kind of what Dr. Singer's talking about. I mean, this is your focus of research, PhD.
Yeah, I was, yeah, thanks a lot, Rob. But I was actually just typing in the comments that, Dr. Singer brings up a great comment that a lot of times the majority of patients, when we do apply these health technology assessments to guide therapies, many of them may not benefit, but a minority of them will, and that ultimately dilutes the power in any trial. With that said, health technologies, like for example, the PA catheter and POCUS, don't always need to result in a drastic change in like patient-important outcomes for them to be adopted, right? There's a entire chain of benefit for these technologies, right? Where even if they improve physician certainty or they result in changes in management on a day-to-day basis, they could still be very valuable for many of the same reasons that Dr. Singer said. You know, no one's, done a study to look at like the pulse oximeter or an ECG to see if it improves patient-important outcomes, but they're still, part and parcel of the care we provide on a day-to-day basis. So I think where POCUS has an edge over the PA catheter is that it's non-invasive, it's a lot more intuitive, and it's a lot more scalable and portable. So it may still very well have a very strong role and a place in the practice of critical care medicine, just because it may end up resulting in like changes in physician management, improves diagnostic certainty, without necessarily having that high burden of, improving mortality to a drastic level.
Yeah, the other thing I completely endorse what you're saying, John. The other thing I'd add is it also teaches you, because it's when you think, again, it's the way I learned, it's at the bedside. You do what you think is right, and then the measurements tell you the opposite. And so it makes you reevaluate what your management plan is. And obviously you've got to challenge, is the measurement technique accurate? But assuming it is, time and again, it sort of highlights to me my my inadequacies, and I've learned from it. So hopefully it's made me a better clinician. But, time and again, it just reveals, if you don't measure something, you don't know the impact, apart from obviously, does the patient leave upright or horizontal? But, you know, it's that knowledge you gain. And again, going back to the point on physiology, it's time and again, you know, patients do the opposite of what the textbooks say, or they respond differently to a drug. But the only way to really know what's going on is to monitor and assess it. And unfortunately, you know, heart rate, blood pressure are fairly crude markers. So a bit more sophistication, I personally think, you know, hopefully not only benefits that single patient in front of you, but future patients.
Totally agree. Yeah, great points.
Are there, if I can, oh, Murat, have a go.
Thanks, Dr. Singer. I had a question about the future of sepsis management. Like, what's going to be happening in 10 years from now? There's been a struggle between monitoring global hemodynamics while we realize that the challenges in microcirculation. So I wanted to hear your comments about what do the next 10 years in sepsis look like in terms of identifying therapeutic targets and developing targeted interventions.
I love the crystal ball gazing. I think there'll be two things. I don't know how, you know, how many of you read. There's unfortunately the nomenclature is a little bit vague, but phenotypes, subphenotypes, endotypes, and essentially there are patterns, and there are physiological, biochemical, biological signals, and it seems that, you know, and you can take out sepsis or ARDS, you know, because there's a lot of overlap with trauma, whatever, but some patients will respond differently to being ill. And so they'll get more or less of an inflammatory response, for example. Their metabolic response may differ. They may get predominantly cardiovascular problems rather than respiratory. And again, it's mainly done on retrospective analyses of trial databases. But what they found is that, you know, treatments, and Carolyn Calfee, who's in San Francisco, you know, she's found differences in outcome with statins and with fluid and with PEEP, depending on your inflammatory phenotype. You know, other people have done the same. Steroids, you know, Hector Wang, who does a lot of, you know, pediatric ICU, again, he's found groups of children that do or don't respond, or respond badly to steroids. So none of these trials have yet been challenged or thoughts have been challenged prospectively, because that's the acid test. You know, can we actually replicate this rehash of databases into a prospective positive result? But I can do it in my rats in my lab, and it works really nicely. You know, however, you know, and other people have too with animal models, but, you know, does it work in patients? I think the second big revolution will come with point of care diagnostics. And it's just scary what's coming through. It's something I'm really interested in. And so I get to see lots of really neat technologies coming through. And so why wait 3 days for the lab to grow something when you can get instant gratification? And it's coming, and there's a whole load of really clever, you know, photonics, for example, where even, you know, there's one company I'm sort of doing some stuff with, where they think you can even do online monitoring. You know, you just have a sort of probe attached to an arterial line, and you'll pick up bugs in the blood. Maybe, you know, whether it translates, because this is all very much done in sort of laboratory setting at the moment, but whether it relates or translates to patients, don't know. We're doing the University of Edinburgh, so I've been involved. There's a study they've got where through a bronchoscope, you put a fiber optic probe through actually into the parenchyma of the lung, and you can actually visualize well, just above the alveoli. So you can see this beautiful architecture, and you can just inject little bits of harmless probes which show up gram-positive bacteria, gram-negative bacteria, fibrosis, cancer cells, and it's just phenomenal. And they've done about 15 or 20 ICU patients without harm. And you'll also, through a channel, be able to suck up a little amount of the stuff and then immediately, you know, get that sample off to the lab. So these sorts of things are the future. You know, there'll be molecular diagnostics where you'll have, you know, 50 or 100 or more, PCR, gene transcripts within half an hour in a machine, blood in a cartridge, put it in a machine, have a coffee, and you'll get the result. And I think, from my argument earlier about sort of companion diagnostics, it will revolutionize what we're doing. The challenge will be affording it, because these things will add a cost. But on the other hand, if you can justify, it will obviously save lives, shorten time. If you can pick up a patient before they become septic, then, that will help the patient in terms of outcome, and it will obviously help the hospital in terms of days in a bed and long-term societal costs, because, we're all now becoming increasingly aware of ICU or hospital survivorship. Because it's all very well, the patients survived, didn't we do well? But at what cost to them and their family? And obviously Margaret Herridge has been flying that flag for many years.
Right. So as long as we can do that within 3.5 seconds, we're going to be good, because we're going to be saving lots of patients.
Indeed. Yeah, might be 5 seconds, but hey. But it will come. It will come, and it's quite gobsmacking how wonderful the technologies are, and also the ability to look at different organs or target different organs. You can have nanoparticles that can target the liver or the kidney, and some people are looking at directed cancer therapies, but there's no reason why. And we're doing some stuff where you can link in antibiotics into DNA nanoparticles which target bacteria, and we're playing with that in the lab, so it hasn't gone anywhere near a patient, but your kill rate is much better at a much lower concentration of antibiotic, because you're targeting the bugs to the bugs directly, and so your concentration of antibiotic at the bug level will be much greater. So I'm an optimist.
Great, thank you.
I wanted to riff on a comment that Karen put in the chat. She might want to expand on it, and it also links back to Dr. Tobin's contributions to our group's dialogue a month ago, speaking about ARDS. And some of the things you're dancing around here really reflects kind of an increased or a poverty of diagnostic language, and maybe a poverty of therapeutic precision, which seem linked. That sepsis is obviously a vague syndrome, and ARDS is a heterogeneous set of conditions that are actually probably affecting the lung. And so by examining outcomes across large trials, there's, we're really just we're not even in the right, we're not in the right level of precision at all. I think in the future, where these diagnostics you're describing would allow us obviously a much more precise sort of subgroups to evaluate therapies, and maybe even change the diagnostic terminology. Karen, am I capturing the sort of the spirit of your comments? And I wondered if you wanted to expand on that.
Yeah, thanks, Rob. It's really a catch-22, isn't it? Because as we, as clinicians and scientists, want to become more and more focused and narrow into exactly the mechanism, exactly the subphenotype of the conditions that we treat, and understand and diagnose it accurately and treat it in a personalized way. At the same time, we have to get the grant reviewers' attention and the media attention and the public's attention. And so it comes back full circle, right? You have to make that point that this is going to impact a lot of people, and this is really important work, and that's why we need this. And yet what we really want is the targeted treatment for the 80-year-old previously healthy with pneumonia from gram-positive cocci with septic shock and renal failure, right? So it's I don't know how we can both make an argument for personalized care and things that maybe can't be shown in a big RCT because it's so personalized.
Very simple, one-word answer: cancer. Because that's exactly what they're doing now in cancer, and they're learning that. And even asthma too, there's learning, asthma's, what's it, 13, I think the latest number is phenotypes or whatever. But you can, if you look at cancer now, they're doing all of the clever immunohistopathology and the markers, and they're working out that actually this patient needs X and this patient needs Y. and certain monoclonals will work with this. You know, it might be lung cancer, but for this patient, we need to treat in this way. And so they're doing it, but they're still calling it cancer, and it's still got the public's attention. And yes, it only treats a certain limited number of patients, but at least, and it's portrayed as a great triumph when it works in that limited number of patients. And they may only capture 2% of the total lung cancer population, but at least it's a step in the right direction. So I'm not despondent, you know, because I think it's like everything, it's how we sell it. And I think traditionally critical care has not been very good at marketing itself. You know, cancer, heart disease, pediatrics have been brilliant because they tug at the heartstrings. You know, so I think, you know, with the cancer, you know, because they've got the money and the depth of experience and the researchers, etc. But I think they're showing us the way. So I'm actually more positive. I think there will be subsets, you know, sepsis, ARDS, acute kidney injury, they're all convenient tags, aren't they? Syndromes, which are a bit, well, semi-meaningless, you know, but it helps us to lump people together. It helps us to do trials because we need to enroll, you know, 3,000 patients with AKI into a study. Notwithstanding the fact that within the AKI domain, there'll be some which will be hypovolemic, some which will be inflammatory, some which will be drug-related, etc. And then we'll come up with different ways of treating each of these conditions. So you don't look so convinced.
So you think we lump under the big categories of ARDS and sepsis for the public, but
and for ourselves too. So we can say within that, so there may be overlaps, you know, 50% of ARDS is an infectious cause, but it might be that some infectious ARDS and some trauma ARDS we can treat in an identical way. You know, and that was, and again, the other thing, it's a bit, I think COVID's a nice example. It's just the evolution of how the lung ventilated in these patients from early through to late. You know, the patients evolve and the phenotype evolves. And again, there are a few studies that have come out showing that patients who go from a good phenotype to a bad one tend to die, whereas the bad ones going to a good one tend to do well, and the bad ones that stay bad tend to do badly. So I think we can still badge them under generic syndromes, but within that we can say, right, targeting, you know, the Bosma subtype, you know, we've shown a great benefit.
Well, thank you for your optimism, because I think we need that in science and in the clinical field.
Yeah, I'm upbeat. Hopefully before I get ill, somebody will have worked out how to treat me precisely.
Well, Dr. Singer, I don't see, I think we've, unless there's any final questions from our group, I think that rounds out the Q&A section, and I'll pass it off to Paul to close things out.
I just wanted to extend my thanks once again, and we really appreciate your years of experience and insight and comedy.
Great hair.
They added quite a bit to our discussion, and thank you for participating so willingly in the question and answer session. I think we've got quite a bit to think of again, and how to place these syndromes that we deal with in everyday life into the context of treating an actual patient in front of you. So I think you've given us quite a bit to think about, and thank you once again for joining.
Great pleasure to interact and say hi to everyone I know, and hi to those I haven't yet had the pleasure of meeting F2F, and hopefully that can change in the not too distant future. So stay well, stay healthy.
We'll have you down in Netherlands.
Thanks for the invite, Paul, and everyone. Bye-bye.
Thank you so much.